Hello, I'm Brianna Aldred, a third-year medical student at the University of Wisconsin. This presentation will cover the pediatric cataract. First of all, what is a pediatric cataract? A cataract is any light-scattering opacity of the crystalline lens of the eye. They can be unilateral or bilateral, and they differ in location and severity. Pediatric cataracts can be present since birth or can be acquired during childhood. Pediatric cataracts are one of the leading causes of pediatric blindness. More than 200,000 children are blind from cataract-related causes. Congenital cataracts, which are those present since birth, account for 20% of child blindness worldwide. In the U.S., the incidence of congenital cataracts is 3 to 4 for every 10,000 live births. The prevalence of unilateral and bilateral pediatric cataract cases is similar worldwide. There are many different etiologies for pediatric cataracts. The most common is genetic abnormalities, which accounts for about 50% of bilateral cataract cases. Ocular trauma and premature birth are risk factors for cataract formation. Pediatric cataracts can also be due to underlying conditions. Ocular inflammatory diseases such as uveitis and scleritis can result in cataract formation if untreated. Congenital infections like the torch infections, especially rubella, are common causes of pediatric cataracts. Genetic syndromes like trisomy 21 and metabolic disorders like galactosemia are also associated with cataract formation. Pediatric cataracts can also result from iatrogenic causes. Radiation and systemic steroid treatment are known risk factors for cataract formation. Laser therapy, such as that used in the treatment of retinopathy of prematurity, can also lead to cataract formation. Many types of cataract morphology have been described in pediatric cataracts. Sometimes unique morphology features can help guide clinicians to a systemic diagnosis. One major complication of pediatric cataracts is resultant amblyopia. Amblyopia is the interruption of normal cortical visual pathway development, resulting in decreased visual acuity. After a child is born, their visual pathways are still developing as they visually experience the world for the first time. Pediatric cataracts inhibit this vision and interrupt the normal visual pathway development. This results in the brain favoring the better eye. The unfavorable eye does not have the proper input to stimulate the cortical visual pathway development, and the brain focuses on developing the better eye. So the eye with the cataract is basically turned off by the brain. The first 2 months of a child's life are critical for vision development, and this development continues until at least 7 years of age. Amblyopia is more common in unilateral pediatric cataract cases, but it can also occur in bilateral cases. The first step and most sensitive test in diagnosing pediatric cataracts is the red reflex. The red reflex is an essential part of every newborn exam and should be checked consistently at every subsequent visit to detect congenital cataracts. As you can see in this image, the child has a normal red reflex. You can see the red coloration to the pupil bilaterally, and it is symmetric. In this image, you see an abnormality in the red reflex. The child's right eye is not reflecting red, but is instead appearing gray. Lens opacities due to pediatric cataracts result in this gray color. A standardized age for vision screening is around 3 to 5 years old. Any child with abnormalities noted on red reflex testing or on the preschool vision screening should be referred to an ophthalmologist for further evaluation. The ophthalmologist is sometimes able to elicit a family history in bilateral cataract cases, since most pediatric cataracts are caused by autosomal dominant genetic mutations. Ophthalmologists are also able to conduct more formal vision testing and slit lamp examination. Unilateral and bilateral pediatric cataracts have a different workup process. Unilateral cataracts are less likely to have an underlying genetic mutation or systemic disease, so they are generally treated without major workup. However, in bilateral pediatric cataract cases, you must consider the underlying cause of the cataracts. If there is clear family history of isolated bilateral congenital cataracts, you can assume the etiology is an autosomal dominant genetic mutation, and you can begin treatment. If there is no family history, you must do a systemic evaluation to ensure that you are treating any potential underlying disease. A thorough history and exam should be obtained to evaluate for signs and symptoms of these underlying diseases. In addition, lab testing should be performed. Torch titers should be drawn to rule out these congenital infections. VDRL should be drawn to evaluate for syphilis. In order to exclude metabolic disorders such as diabetes and hypoparathyroidism, you should check serum calcium, phosphorus, glucose, and galactokinase. Urine testing evaluating for the presence of reducing sugars and protein products should be completed to identify any inborn errors of metabolism such as galactosemia. Genetic testing may be utilized on a case-by-case basis. If a cataract is less than 3 millimeters or not very dense, you can pursue non-surgical treatment. You can use part-time patching to prevent amblyopia. Placing a patch over the better eye impairs its ability to focus and forces the brain to favor the weaker eye, ensuring adequate cortical visual pathway development. Cataracts that are eligible for non-surgical treatment must be monitored regularly for progression. More often, surgical treatment is needed for pediatric cataracts. Surgery is indicated if the cataract is greater than 3 millimeters, if it is in a central location, or if it is dense. Cataracts with these qualities must be treated by 16 weeks of age in order to attain visual acuity greater than 20/40. For unilateral or asymmetrical bilateral cataracts, surgery should be done by 6 weeks of age. You can use patching prior to surgery. For symmetrical bilateral pediatric cataract cases, surgery should be done by 8 weeks of age for the first eye, with the next surgery in 1 to 2 weeks for the second eye. During surgery, an intraocular lens pictured here can be placed. Alternatively, the child can be left aphakic, meaning their eye or eyes have no lens, and they can use glasses or contact lenses after the surgery. They can have their intraocular lens placed at a later date when visual acuity is better able to be assessed. Pediatric cataracts and adult or age-related cataracts have similarities and differences. In regards to morphology, as we discussed previously, there is a wide variety of different pediatric cataract morphologies depending on their etiology. In adults, there are 3 primary types of cataract that are age-related. Pediatric cataracts should be surgically treated quickly to avoid amblyopia. However, adult cataract surgical removal is performed only once the cataract is significantly interfering with daily life and activities. Different surgical methods are utilized in pediatric versus adult cataract surgery, which results in unique surgical complications in the different populations. After surgery, children can be left aphakic and have intraocular lenses placed in the future. However, adults are rarely left aphakic, and intraocular lenses are placed during the initial cataract surgery. This concludes the pediatric cataract lesson. Thank you for listening.